Hello, today I will be speaking to you about Greek stroke caregivers. What are the best and most cost-effective forms of OT and peer support for informal carers of stroke survivors? A review of the international evidence applied to the context of Greece during times of austerity. Stroke is a chronic disease with long-term residual consequences for many patients. There are various health and rehabilitation professionals who are dedicated to improving stroke victims' functional independence, OTs, PTs, nurses, etc. Yet there is another vital team member, the family caregiver. The needs of this hidden health professional, also known as the hidden patient, are often overlooked. Unfortunately, the caregiver is rarely aware of the lengthy process of recovery after neurological insult and what caring for that individual actually entails. They often cannot successfully fulfill their other personal occupational roles and stop caring for themselves, all while trying to mourn the loss of their pre-stroke lives. The greater part of their day is invested on occupations directed towards the stroke survivor. The caregiver's own preferred occupations may be put aside, and carrying out occupations outside of the house may depend on the care recipient's daily condition. Caregivers often experience a decrease in the joy of occupations overall, and these factors directly relate to caregiver burden. Now, caregiver burden is a multidimensional notion involving social, psychological, as well as financial factors. Pioneers in this field, Zarit and colleagues in the 80s, described caregiver burden as the state resulting from the necessary caring tasks or restrictions that cause discomfort for the caregiver. Negative aspects of caregiving may include physical strain, exhaustion, financial stress, isolation, loss of autonomy, feelings of anger, anxiety, and uncertainty. The sudden onset of stroke and its devastating effects lead to change in loss in roles, relationships, and lifestyle for the carer as well. All these factors, including reduced participation in valued activities, may lead to decreased quality of life and depression. Noteworthy are also the positive effects of caregiving. Changes in sense of fulfillment and being able to manage a situation, closer relationship to the care recipient and other family members may also develop as a result. It has been observed in studies carried out in Nigeria that stroke survivors who enjoyed family care had faster recovery of functional performance, were unlikely to have emotional disorders, and had better quality of life than those who did not enjoy family support. Yet it has been documented by several authors that caregiver depression may increase stroke survivors' depression and minimize rehabilitation results. Thus, the effects of caregiver burden not only concern the caregiver, but the care recipient as well. As OTs, we possess unique skills which enable us to assess the needs of caregivers and intervene to assist them in adjusting to their new occupational roles. The model of human occupation is a tool that can help guide the OT to provide effective caregiver intervention. The major value of MOHO lies in its holistic view of the individual. Change in MOHO involves the restoration of order of the person's internal and external life structures. Specifically for caregivers, intervention needs to be addressed to address its habituation and performance subsystems, specifically roles, habits, and skills constituents, respectively. It has been found that high task difficulty and low self-esteem increased emotional distress in caregivers. It is crucial to empower them with the knowledge and skill required to successfully fulfill their new occupational roles, which will hopefully decrease their burden. Another example may be identifying the imbalance in caregivers' social functioning secondary to increased responsibilities. Suggesting and providing additional activities to their routines, attending support meetings, allows caregivers the opportunity to make new social contacts, support, and working towards achieving balance. During the extensive literature research and review, it became obvious that caregiver support is a concern worldwide. Many researchers spoke about how caregivers require different information throughout the stroke continuum, with the timing and right research being the most comprehensive. Jill Cameron and her Canadian colleagues created and studied the TIR conceptual framework. She believed that caregivers' informational needs are different at the 5 different phases of recovery identified. For example, during the event and diagnosis phase, carers appear less capable of taking in and processing information and just want basic medical information regarding the stroke and its medical management. Information on rehabilitation options and regarding transfers and other ADLs are imperative during the preparation for discharge phase, during the first months of returning home, the implementation phase. And information regarding community services, support groups, etc., is most requested and needed in the adaptation as well as the implementation phase. Understanding that stroke caregivers' needs change over time and separating needs into phase-specific categories helps guide the health professional trying to implement the support and structure the educational materials. Other research the best way to deliver the education and support, how best to validate and ensure the efficacy of these methods, which healthcare professionals should be implemented, what kind of support, and when were all questions, that have been yet to be clearly answered, although they have sparked recent research. Again, although it is often mentioned as a concern, little has been published in regards to the cost effectiveness of programs and being implemented today in the rehab community. I've specialized in stroke rehabilitation for 20 years and have worked in an outpatient private practice with chronic stroke patients for the last 12 years in Athens. Recently, the time post-stroke of my referrals have been shorter, and I have begun noticing increased levels of stress and anxiety amongst their caregivers. Here in Greece, there has been no past, nor is there a current system officially in place specifically providing caregiver education and support. There are no official handbooks utilized in patient facilities. There are also no support groups available for stroke caregivers, and with the current crisis, things have worsened. Less money is available for covering home care, nursing, and therapy costs. Reimbursement has been made very difficult, requiring committee approval, and most rehabilitation facility costs here in Athens are not supported by government funds. Thus, there are more patients being discharged directly to their homes and once they are medically stable, and with both patient and caregivers missing out on the potential guidance of the inpatient rehabilitation staff. Even as unorganized and informal support, at least it is better than no support. What is obvious is that there is great need for intervention here in Greece to support the stroke caregivers. So what are the best and most cost-effective forms of OT and peer support for informal carers of stroke survivors in Greece during these times of austerity? Well, the first step in empowering the caregivers is to give them the information that they need to successfully fulfill their occupational role. Caregiver training has been found to improve caregiver mood, quality of life, and reduces burden of care. Carers' experience was best when they felt better prepared for duties. In a qualitative study looking at stroke caregiver experiences, the carers who had the opportunity to spend many hours with the care recipient at the rehabilitation facility benefited from informal instruction on transfers and ADLs by the therapist. In Greece, the frequency of in-hospital caregiving is high. This occurrence began in the 1980s when the government introduced an open visiting hours policy. The intention was to increase opportunity for in-hospital informal care in a response to nursing staff shortages. Now, this phenomenon creates a unique opportunity for caregiver education, however, appears to remain unexploited. Now, prior to discharge from inpatient facilities where OTs are employed, the OT should ask the caregiver to attend last few sessions so to be trained in self-care, transfer skills, etc. This requires no additional costs and just a change in OT session planning and goals to include caregiving. For example, the National Institute for Rehabilitation in Athens has a separate ADL rotation within the OT department which could host this type of caregiver training. Training could be done via demonstration and verbal instruction with repeat demonstration by caregiver to assess the efficacy of the training and skill competence. Allowing caregivers to record sessions on their video cameras or phone cameras may assist in recalling and techniques and tips at a later date, alleviating stress of becoming successful and competent in everything in just 2 sessions. Now, the need for written education to support verbal information given to caregivers has been identified by researchers. How best to provide this information is still to be determined. General stroke caregiver manuals are common literature in other Western countries, but it has been found that individualized material based on the needs of each caregiver is most beneficial. Tammy Hoffman and her Australian team studied a computer database system which dynamically compiled individualized stroke education booklets for patients and their caregivers. The family members could choose type of information, the amount, detail, and font size. If we were to apply this in Greece, the information in the database could be produced as an initiative of the SE Hellenic Occupational Therapists Association Special Interest Group, ONOE, which is orthopedic and neurological occupational therapists. In the past, we members have produced a basic handbook describing the stroke patient's care continuum from diagnosis to community, and then began to work on a handbook for stroke patients focusing on patient functional skill training. The unfortunate fact, though, is that we never considered focusing on caregiver education and support. Now, in order to reach more caregivers throughout Greece, this database should ideally be accessed online via Greek caregiver website. Prior to discharge training, the OT or health professional can go through the process of assessing and utilizing the caregiver site. The carers can look and choose topics to print depending on their current phase specific needs and refer to the site from home in the future according to their new informational needs. For the older caregiver that do not use computers, the OT can dedicate the session to assisting the caregiver with site exploration, review the informational choices, suggest additional information that might be beneficial in the future. The OT can assist with compiling information booklet, which can then be printed out. The cost of printing can be absorbed by the rehab department or may be sponsored by organizations like the Hellenic Stroke Association. Now, the TRACS trial in a large UK-based multi-centered RCT studied the impact of a structured competency-based program for caregivers in 36 stroke rehabilitation units. And even though the researchers found that this intervention yielded some improvements, improvements were not statistically significant when compared to the control group. And the authors concluded that the intervention approach might be more relevant if delivered after discharge by community-based teams. This is just one of many reasons why the development of community-based services is so crucial in supporting caregivers. However, given the current situation in Greece, focus should be developing stroke support groups within the community, especially for the older population who is not so technologically savvy to benefit from from the website information, chat rooms, and forums. Most municipalities in Greece have a KAPI, which roughly translated stands for Recreational Center for the Elderly. This would be an ideal venue for caregiver peer support groups to be hosted. It has been suggested that these support groups should ideally be coordinated initially by a health professional, and OT's training is optimal to take on the role of coordinator, and with the hopes that the caregiver will feel empowered to volunteer to take on leadership responsibilities in the future. Example of topics to focus for structured meetings could be socialization, coping strategies, problem-solving techniques, relaxation techniques, etc. The goal should be utilize these meetings to empower the elderly caregiver with need-specific strategies and information they would not be able to access otherwise. And for the younger caregiver, there are other cost-effective ways to utilize technology. A series of YouTube videos focusing on the already identified educational needs of caregivers would also be beneficial. Hellenic Stroke Caregiver Facebook page could also be developed and allow for increased opportunity for social interaction, information sharing, and peer support. Now, to support the caregivers appropriately across stroke trajectory, problem-solving skills and stress coping skills should be included in the intervention. However, in a study carried out by Chinese health professionals in Hong Kong, it was found that the social and emotional costs on family caregivers from the caregiving process did not appear to be minimized either by psychoeducational or by social support groups alone. It is important to keep in mind that better results were seen when implementing both together. A cultural obstacle to be considered is the value Greek families place on caregiving. From experience and anecdotal evidence, Greek caregivers feel they are failing their loved one if they allow the care recipient to do most of the ADLs and self-care for themselves. Swedish OT Van Dongen et al. In 2014 stressed that the caregivers must educate and be assured of the therapeutic benefits involved in taking a step back from occupations that they initially had taken over after stroke. This should be stressed during caregiver instruction because it enables the care recipient to learn to perform tasks independently, and this provides both caregiver and care recipient with more autonomy. Also to be considered in this is the communicative and psychological changes in the patient, aphasia, dependency, immature behavior, general personality changes, often cited as major cause of stress among caregivers. Thus, carers may benefit from counseling regarding these changes and how to deal with patients' moods. Ultimately, given the situation in Greece, nothing can be developed and implemented until the therapists change their intervention focus from a traditionally medical model of patient-focused therapy to a more holistic caregiver patient-focused intervention. Presenting the concerns and ideas mentioned here at OT, PT, and medical stroke conferences and to the Greek OT Association special interest group mentioned earlier would be the best place to start. We need to educate and motivate the health individuals to empower the caregiver, which one hopes will improve quality of life for carers and care recipients alike. Thank you for your time.